Okay, welcome back. I am delighted to introduce Dr. Ruth Etzioni, who is a professor of biostatistics at the Fred Hutchinson Cancer Research Center, where she is a professor and member. She's also a fellow of the American Statistics Association and leads its health policy section. Ruth is really a thought leader in, I think, what Dr. Curry referred to is that dotted line. I think Ruth really helps to think about what to do, how to solve complex analytic problems related to inference in cancer screening, surveillance, and the dotted line problem. And she's going to talk to us about cancer risk prevention. Welcome, Ruth.
Thank you. Thank you. Thanks, Deb. Are these yours? Okay, yeah. Okay, now I know how to describe what I do. I do the dotted line problem. It's always really hard. I talk about getting the numbers right or filling in the evidence gaps that inevitably arise when you're trying to make good policy. So the topic of my title today is cancer risk prediction, sidekick or critical partner in early detection, and I'm happy to have the opportunity to bring together some of the key topics of today. And just as somewhat of a spoiler, I'll just say that my answer, at least, is not sidekick. And we'll get into that. But just to begin, I want to kind of look backwards. It's always instructive to look backwards. Sometimes, when I haven't thrown a newspaper away for several months, and then then I look at the newspaper and all of the prognostications that, were 3 months ago, and with the hindsight can kind of take a fresh look. It's always good to look back. And so when you look back at cancer screening, you find posters like this from the American Cancer Society. Early is the watchword for cancer control. Early diagnosis, early treatment will save many lives. Early cancer can be cured. Mammography can detect breast cancers even smaller than the hand can feel. We urge women without symptoms of breast cancer, ages 35 to 39, to have 1 mammogram. For the record, women 40 to 49 to have a mammogram every 1 to 2 years, and women 50 over and over once a year. So a lot of a positive sentiment about screening, a lot of exhortation to go out and get the screening tests that were available. So fast forward to now, or to the last 10 years, and we get headlines like this one, mammogram's role as a savior is tested, or this one, the great prostate mistake, or this one, it's time to rethink early cancer detection. And there was a sidebar in this article, and the heading on the title on the sidebar was Fatal Retraction. And of course, these last 2 articles were focusing very much on the issue of overdiagnosis and overtreatment. And since I'll be talking much about overdiagnosis during this talk, I want to make sure that we all have got a clear idea of what I mean when I say overdiagnosis. So I'm talking here about the problem of when screening detects a cancer that would not have surfaced during the lifetime of the patient in the absence of screening. And so just with the figure over here, so here we have a point at which when the cancer would have surfaced, and here's the point of screen detection. This is the point of cancer onset. And in this particular case, the latent period here in the gray extends beyond the point at which the patient would have died of something else, either because of the characteristics of the patient in terms of age or comorbidity, or because of the characteristics of the cancer in terms of latency and indolence. So going back now then to this question of why is there this pause in the attitude about early detection? And I think it has to do with the fact, and I'll partly attribute this to some of the metrics that the task force actually has helped us to understand the absolute harms and benefits of cancer. So the reason why is that cancer screening is early detection is really complex And the complexity partly comes from the fact that we're intervening in the entire healthy population to save a few. So our benefit, our lives saved, can only be a fraction of the lives that would be lost. And for any particular cancer, that's a few percentage points. How many women will die of breast cancer without screening? It's between 2 and 3%. And so our benefit, the fraction of the population that we can benefit, is only a fraction of that small amount. And the problem then is that the harms and the costs are a function of an order of magnitude larger population. So for example, overdiagnoses are a fraction of the cases detected by screening. And false positive tests are a fraction of the individuals who screen positive, and that's an even bigger sample size. And this harm, and of course the number of tests, the number of people that we touch and intervene in. And I have to tell you that I think about this every time I go and get a mammogram, and I put on my little green gown, and I'm sitting in a room full of women, guys, you won't know this, but full of women in little green gowns. We're all being touched by this intervention. And so the potential for harm in terms of absolute fractions is a lot greater than the potential for benefit. And this is very much on the mind of the task force. So, of course, Sue already talked about the D recommendation, which caused shockwaves in the urology world. But when you look at the discussion of the justification for that recommendation, all of the language is around these the harm-benefit trade-off, and I've kind of bolded some of the key words here. And just to to just really hit the message home, this was actually a graphic that was published to kind of explain the reasoning at the time. And so this is 1,000 men who get screened for prostate cancer, and the beneficial, in this case, the man who benefits is the 1 in 1,000. And I have a star here because we tried for a long time to convince that the 1 in 1,000 was a short-term rather than a long-term benefit, and over the long term the benefit would probably be 5 or 6 times that, but still the other colors are all men who have been touched and potentially harmed, and so you can see that trade-off. So this brings us to then the reason why risk stratification is not a sidekick, or in my opinion cannot be a sidekick. It needs to be a partner. Because with risk stratification, we then get to increase the size of that smallest circle in the higher risk population where there's more potential for benefit. And we already have a large number, or fair number. I'm going to argue at the end of the talk that I think that we need to come back to the drawing board and think about further novel risk stratification metrics, particularly with the technology that's now available to us. But we have risk stratification metrics that span from demographic to genetic to acquired risk due to exposures, precursors, or biomarkers. And those are just the ones that I could think of. I'm sitting down to prepare the talk. And so here's a few examples. I like this one because this is a GWAS article from the Practical Consortium, but I just like the quote, which reinforces my reasoning and the reasoning behind risk stratification. That if we have a higher risk subpopulation, that when you look at harm relative to benefit, the denominator of that is going to be greater, and therefore you're going to have more potential for a more reasonable harm to benefit trade-off. Here's a biomarker one that's become of great interest in the prostate cancer world, and this is work by Andrew Vickers and Hans Lilia, where they looked at the Malmo Preventive Project, and this work has also been confirmed in work from the Physicians' Health Study here, looking at, in this case, blood that was drawn, and then 25 years later, looking at the cumulative risk of prostate cancer, and then going back to those stored bloods. And so this is among younger men, and this is showing the time from baseline over 25 years, and prostate cancer, actually the risk of prostate cancer metastasis for the highest quartile of PSAs at the time of blood draw versus the lowest quartile. And so this is an idea of using this biomarker to tailor screening when men begin to screen. But I also want to show you this work where they did the same thing among men at age 50, and it's a slightly different graphic. So here we have the PSA distribution, and here we have the 25-year cumulative risk. Look at the middle curves for cancer. These are the confidence intervals, and metastasis or death over 25 years as a function of that prostate-specific antigen at the time of blood draw. And here, just lest we think of stratification only for high risk, this is an idea to stratify for low risk, and essentially the recommendation that came out of this work, and that has really started to gain traction, is that if men who've been screened still have a PSA less than 1 at age 60, to just stop screening them because they're that low of a risk. And the idea being, based on just these observations, that those men will be, stopping screening those men will reduce overdiagnosis and screening without sacrificing lives saved. Here's the task force guideline for lung cancer, very, very focused on high-risk population based on smoking history. Here's the American Cancer Society's recommendation for colorectal cancer, where different guidelines for people at average versus people at increased or high risk, where the high risk is a personal history. You have to have had a colonoscopy to know that you're high risk of having polyps. And here's a demographic one that I'm going to spend quite a bit of time on in the talk, and that is the recent recommendation for prostate cancer screening, which singles out African American men who have among the highest prostate cancer risk in the world, with a mortality double that in white men. Both mortality in the general population and in African American men has come down considerably, but the ratio is still of age-adjusted prostate cancer mortality is still about 2. But it doesn't tell us what to do. It tells us to consider that when making a decision about prostate cancer screening. It doesn't tell us about what to do. And that leaves us with a question. And that brings me to possibly the main point of today, which is that while it's not a sidekick, it's not yet a partner. Risk stratification is only the beginning. And to make it a partner is going to take several more steps, and I'm going to talk about those in the rest of the talk. Knowing that risk is higher within a specific subgroup doesn't tell us what to do. Should we screen them earlier? Should we screen them more often? Should we make it easier for them to have a biopsy, for example, a lower PSA threshold for biopsy referral? And to answer, and this is going to be the first step, we actually need to understand how the risk differs across subgroups. And when I say risk, I mean that when we say risk differs across subgroups, that's actually not a precise statement. One group is higher risk than the other. Typically, it means that they have a higher incidence of diagnosis in whatever study was being used to assess incidence. But it's actually not entirely clear what that means. Was it a screened cohort? Was it non-screened? Was it retrospective, prospective? So we really have to understand how risk differs across subgroups. And here I'm talking about, is it disease onset? Is it disease aggressiveness? Is it survival? I'll talk about onset and aggressiveness in the remainder of the talk. Is it both? And the reason why it's so important to understand this is because if it's onset versus if it's onset and aggressiveness, are going to have different implications for those downstream harm and benefit that are most important when you're trying to make good policy decisions. And what I'm going to show you next is projections of harm and benefit from a model that we've spent many years developing that I'll talk a little bit about later, but very little about, just to keep things high level and on a visioning level. So I'm going to show you harm-benefit trade-offs from our prostate cancer model. And for harm, I'm going to just look at overdiagnosis. And for benefit, I'm going to look at lives saved. And I'm going to look at absolute projections. And so on the next slide are 2 graphs. And let's focus on the left one because I want to just explain this graphic because you'll see it many times. So on the x-axis is the probability of overdiagnosis. And on the y-axis is the probability of life saved. So you can see about around 1%, based on the benefit of prostate cancer screening and the fraction of men who will die of prostate cancer, which is around 3% without screening. And every point on the graph is a strategy. And there's different strategies. They vary by ages. There's a key on the right-hand side. The darker points end earlier at age 64. The lighter points end later. The small points are screening every year. The big points are screening every 2 years. And all of those strategies, their harm and benefit are projected on the graph. And this line here is some threshold. In this graph, it's the harm to benefit ratio equals 5. That's what we calculated, more or less, was the long-term harm-benefit trade-off of prostate cancer screening. So just look at the graph quickly and think for a second, where would you want to be on this graph? Whoops. What happened? There we go. Where do you want to be on this graph? Well, you want to be here, right? You want to be where the benefit is high and the harm is low. And so above the line are kind of, if you think of this line as a threshold for acceptability, above the line are the strategies that are more acceptable, and below the line are the ones that you would maybe find less acceptable in terms of a threshold that you've, in this case, the threshold of 5 for harm to benefit. Okay, so that's kind of, that's the graphic, we'll see a few more of them. And on the right, that's the same graphic for a population that has an increased risk of disease onset. It's double the risk of disease onset. So what that means is that there will be considerably more cases of disease in the population, right? And therefore, more lives to be saved. So you can see that the benefit is greater in this population, but also the harm is greater. And maybe that's surprising. You have a higher risk of disease, but it's only risk of onset. So what that means is that there are more cases, but there's also potentially more overdiagnosed cases. So both the harm and the benefit increase in a population where only the risk of onset is increased, and that's your high-risk population. Now I'm going to go to the next slide, and it's going to be exactly the same, except the right-hand curve is going to be the increased risk of onset in this high-risk population. Men have also an increased risk of prostate cancer, and they have an increased risk of aggressive prostate cancer. And I have exactly the same strategies. And look what happens. Okay? So benefit is pretty similar, but the harm comes down with all of the strategies. And all of the strategies are now acceptable. So I can toggle between the two. And the point that I'm making is that how does risk differ actually is very predictive of the downstream outcomes and can potentially change which strategies are more acceptable. And so understanding how risk differs is important to get to that designing good policies. So that's the first step. Risk stratification is only the beginning. The first step is to really understand the risk. And I always said to myself, why did I have to get interested in understanding the latent events in cancer progression? Because really, onset is a latent event, right? Progression to a later stage is a latent event. Why did I have to get interested in things that were unobservable? Why couldn't I be interested in things that were observable? But I've always been interested in the unobservables, and we can learn about the unobservables, and there's a history of this work, not only in cancer, but also in HIV, because we can learn about these unobservables from observable data. So now I'm just going to take you through thinking about this. What you need is you need to have incidence of disease with and without your screening test, because if I have incidence without screening, and now I start screening, and my incidence goes way up, then that difference tells me a lot about the latency of the disease. And if I have data not only on incidence on disease with and without screening, but on stage distributions with and without screening, and if I have a longitudinal screening cohort study where I have screening histories over time, I can learn a lot about these histories. And in fact, all of these papers that I've got on this slide, and you can look at the titles, are really focused on this individual level screening data. And when we were doing our prostate cancer model, we did not have that. We had population data. We had population data with and without screening, and we had to reconstruct screening utilization patterns in the population, but we essentially did a population version of these models. And now I'm going to show you the fit of that to population data from SEER for here all races, and then here is for African American men. And so the black is SEER data before and after screening. The top row is localized cancer, and the bottom row is advanced cancer, and you can see just really interesting features with tremendous increase in incidence once screening came in. This is when screening came in for localized disease, and big drops in advanced stage disease in both cases. And the black is the SEER data, and the orange is our best fit. And so what do we learn about risk? So we learn that African American men have a higher risk of onset. They get cancer earlier. At all ages, they have a higher risk. They don't have a longer latency period or a shorter latency period, but within that latency period, they're more likely to metastasize. And so this becomes very informative, because in step 2, once we understand this, we now can do the translation to those curves, to those plots that I showed you. And I just have one slide about that translation, because those of you that are familiar with decision modeling will know that we can take what we understand about these histories and turn them into a virtual population and use simulation techniques or analytic techniques. We use simulation techniques to superimpose screening strategies that then detect cases early based on the diagnostic performance. So we take the diagnostic performance, we interact that with our natural histories. This gives us the earliness of detection and helps us to generate estimates of overdiagnosis. And then we have a very important step. We have to have a translation of that earliness of detection into a delay in disease-specific death. And this, by the way, is the rub of every model of screening, from screening to outcomes. What is the assumption about how early detection delays disease-specific death? And is there, perchance, something to validate that against? A trial, for example, a screening trial. We don't always have that. Or is it more of a mechanistic assumption that if we move cases earlier, to say an earlier stage by early detection, that translates into a commensurate extension of life? And then once we have that virtual population with screening and these outcomes, we can tell you the costs and harms. So that is, a good 10 years of work, and now this is the result for African American men, because they have more higher risk of cancer and more aggressive cancer. These strategies are sitting in the acceptability region, and earlier and more frequent screening is potentially preferred for this population. But just to hit it home, we also, when we took our results, we also then constructed a cumulative incidence curve, not of disease onset, but then coupling that with what we know about survival, onset of disease that, if not treated, not detected, would lead to mortality. So onset of potentially lethal cancer. And we drew a curve for African Americans and for all races. And what we did then was we looked at the new C recommendation from the task force, which says US men age 55 should engage in shared decision making. And we looked at the burden of potentially lethal disease in the general population and then in African Americans. And we find that the African American burden reaches equity with the general population burden 10 years earlier. And that then gives us a very clear justification for what people have said for a long time. Start screening African American men 10 years earlier. Yes, that seems like a reasonable idea. Again, if your objective is this kind of equity of, when we think about screening high-risk populations or subpopulations, we always think we should screen them more aggressively. And perhaps why are we thinking that? We're thinking that because we want to give them the same chance to benefit as the average risk population, and that's captured in this graph. And just to show you again what we can do then with this virtual population is we can inform about this question of whether stopping screening at age 60 is a reasonable idea. And so on the left, we actually have the PSA curves that are superimposed from our model and from that Malmo project, and then our projected risk of the 25-year risk of diagnosis and against their projected risk of 25-year diagnosis. And then when we kind of model out these downstream outcomes, we actually find that if you've been screened and you have a PSA less than 1 at age 60, it's actually a good idea to stop screening. It's going to reduce your exposure to screening. It's not really going to reduce overdiagnoses or lives saved, because men who have a PSA less than 1 at age 60 will never be overdiagnosed. They actually must be on a very, very low trajectory of PSA growth. And so, yes, it's a good idea because it's just going to really reduce the testing burden, but don't expect it to reduce overdiagnosis. Okay, so I hope this is kind of opening up the thought and kind of fleshing out the idea that risk stratification is just the beginning. And in the last few minutes, I just want to, rather than focusing on the high risk or the low risk population and what should we do, I want to build out this paradigm of having a heterogeneous risk population because ultimately what we want to know is, should we risk stratify the entire population or should we not? And how do the harms and benefits pencil out when we put the high and the low risk strategies together? And it's very difficult to do this in general. So I'm just going to do this in a case of two groups, where you have a kind of a population risk of disease onset that can be partitioned into high and low risk groups. And I'm going to say, what if we just screen the entire population? I'm going to take, for example, age 50 to 69 every 2 years, versus screening the high risk group more intensively every year beginning earlier, and the low risk group less intensively every 5 years beginning later. And I'm going to have two numbers. First of all, how many in that high risk group? So often we're thinking we have a high risk group, but for example, with BRCA, which is important for prostate as well as breast cancer, a small percentage. So is it worth testing the whole population to find that small percentage and then intervene? And so, or should we just screen the whole population and hope that we catch those cases? And so we're kind of comparing two population settings. And I'm going to look at two proportions of high risk and two levels of high risk. And so on this next slide, so there's M is the level of risk. So the high risk group has twice the risk of the population. And here the high risk group has 4 times the risk of the population. And here the high risk group is only 10%. And here the high-risk group is 20% of the population. So the first thing we have to do is, if we know the risk in the high-risk group, right, and we know the average population risk, we have to figure out what's the risk in the low-risk group. So here's the so these are just survival curves to the time of disease onset. And I'm only going to show you all of these results in the case where the onset is different in the high-risk versus the low-risk groups. And so just to take a look, right, so this is M equals 4. So the high-risk group is 4 times the risk. So the survival obviously is lower. And this is the time to disease. Okay, many more men eventually will get disease. And we can spend a whole lot of time looking at these, but this is how it partitions out when we solve for what the low risk must be given the level of the high risk and the fraction high risk. And so when we talk about high versus low risk in each of these settings, these are the differences that we're talking about, and the average risk is the same in all settings. So remember I said we're going to screen the low risk less intensively and the high risk more intensively. So on the next curve is our overdiagnosis versus life saved graph within each of these 3 strata, with the size of the point more or less indicating the size of the stratum. And so the first thing we see is that, as expected, within the high-risk stratum, because we're screening them more intensively and the difference is only an onset, they have more benefit and they also have more harm. And the low risk has less benefit and less harm because they're being screened less intensively. And it's quite extreme in the case of the higher risk of onset, because that does give a lot more benefit but also a lot more harm. And one of the main things I want to take away is that you can increase intensity of screening to get benefit, but in the case where you have overdiagnosis of the cancer, you may also be increasing harm to beyond a sustainable point. So now what happens if we look at the whole population? So we're kind of going to look at the average risk population, then we're going to look at kind of a population that combines high and low risk in the proportions P, 10 or 20, 10 or depending on P. So here's the harm-benefit trade-off of the overdiagnosis life saved of the risk-stratified approach versus just screening the whole population. And you can see they're very close. But this is a good thing, because of the risk-stratified approach, we would hope we don't lose benefit, but we hope that we don't intervene so intensively, and we can actually reduce our footprint in the population. So here, I'm showing you some of the other outcomes. PSA tests per person for average risk versus the risk stratified approaches, false positives, and then overdiagnoses and lives saved. And these are a little higher here because remember, this is P equals 20%. So we have 20% high risk, and we're doing a lot more to them. But generally, we can bring down this footprint of how much we intervene in the population. So I haven't actually even, is it worthwhile to do risk stratified? I haven't told you how much it costs to stratify the population. You know, how much does it cost to actually figure out who's high risk and low risk? And that will have to be taken into the account in the calculation. But this is a huge part of the calculation. And then has to be traded off. How much we're doing fewer tests and fewer false positives, we're trading that off against the cost of somehow assessing the entire population for their risk. So just a couple more slides. Essentially to conclude, I hope I've justified to you why I think that it's not a sidekick, but to make it a partner needs actually more data, more thought, more steps. But I think that with that, I think it really can be a partner. I think it's a critical partner. And it's a critical partner because of the technology that we've heard about today, that's going to offer us the opportunity potentially to detect less common cancers, when that circle for the benefit is going to shrink even further, because those less common cancers kill a smaller percent of the population, and so there are fewer lives to save. And this is just one from last year. This is the CancerSeek paper. I didn't have any slides from Sam today to show, or Sangeeta, but we're looking at an explosion of technologies that are going to be able to detect these rarer cancers. And so how is this going to pencil out? And so what I want to just end with is this thought of really thinking outside the box in terms of the risk stratifiers that we have. The risk stratifiers that we currently have, we've had for a long time. And so can technology and data help us to make screening sustainable? And Sam said something important today. He said the technology is ahead of the biology. And I would maybe posit that the technology may be ahead of the epidemiology, but that's a great motivator to bring both the biology and the epidemiology in line with the technology. So thank you for your attention. And